So welcome everybody. It's the first rounds of 2022. It's hard to believe we're already sort of at the tail end of January. I just wanted to start off today by recognizing for those of us attending from the Kingston area that we're situated on the traditional Anishinaabe and Haudenosaunee territories. And I'm just looking outside on this beautiful wintry day that I have yet to be outside in and just give thanks for these lands and the opportunity to take time over the next hour to be present as we consider how our research at HSPRI can help support principles of equity, diversity, and inclusion. And I'm particularly thrilled to introduce Dr. Colleen Davison. So this month, Colleen steps into the inaugural role of the Associate Dean of Equity and Social Accountability at Queen's Health Sciences. So we jumped on the chance to have her talk in her first month at the research rounds and start the year off by, as a group, consciously working to build the knowledge and capacity at HSPRI to conduct equity-oriented health services and policy research. So thank you, Colleen. So Colleen, for those of you who don't know Colleen, she's trained as a social epidemiologist and global population health researcher. And today she'll share lessons with us from this vantage. And so Colleen has a long list of impressive accomplishments. And so I'm just going to put a link actually to your bio in the chat, Colleen, for people to take a look at. I also thought before we get started, I just wanted to acknowledge that it is Mental Health Promotion Week. And specifically today, it's Bell's Let's Talk. And, I know we're all, particularly in this last wave, grappling with the challenges of working and being at home, and just wanted to acknowledge how important it is for us to think about health promotion this week. And also acknowledge that HSPRI's Heather Stewart holds the Bell Mental Health and Anti-Stigma Chair at Queen's University. And she's going to be presenting next week on the nature and nurture of mental illness and stigma, I should say in February. So Colleen, I'm going to hand the floor over to you and stop talking.
Thank you so much, Catherine. It's wonderful to be here with everybody. Just going to share my screen and I'll bring my slides up so I can. Yeah, so I'm really pleased to be able to speak to you today. I'm glad to see most people have their videos off, because I think on Bell Let's Talk Mental Health Day, maybe you can stand up during the presentation or have your lunch or cuddle with your pets or even put your earphones in and go for a walk. I don't know. I'm all supportive of that. It's wonderful to see so many people here, but I also recognize that it is the lunch hour. And so I totally understand that you are, with your screen off, but feel free to also put your screen on if that makes you feel more socially connected, or if you are here to support me. Thank you so much. So I'm going to be talking about equity-oriented health services and policy research. I'm going to try to bring in some social epidemiology and some critical race theory. So let's get started. Like Catherine, I do want to acknowledge the land, the traditional land of the Haudenosaunee and Anishinaabe people here in Kingston. I also want to recognize that I'm a white woman, and I came from Cape Breton, Nova Scotia, where my ancestors originally arrived in 1817 on a boat. They were exiled from Scotland, and the British authorities at the time said, well, we'll give you some land, very dense forested land in Cape Breton, and we'd love you to set up some colonies there. So my establishment in Canada, my ancestors' establishment in Canada, were directly a result of colonization. And I recognize the continuing need for reconciliation about the negative directions we've been going since that time, and the widening inequities that we see between Indigenous and First Peoples and colonizers or settlers. I want to also recognize that some of the themes that I'm touching on today are from some interactions I had with the Race in Epidemiology Task Force. It was a group that was put together and still continues to this day, that's student-led in the Department of Public Health Sciences, which is my home department. And this was led by Serena McDonald and others, and really some of the ideas were inspired. And I really want to say that I appreciate the students for continually pushing us as faculty to be the change that we want to see. And so I just wanted to acknowledge that today. So the talk's going to have 3 parts. The first is sort of the why, or the background assumptions that I work from. The second part is the what, critical race theory methodology I'll talk about. And then the third part is the how, and that's how does this, or how can this be applied specifically in health services and policy research. course, there we go. And the first thing I did when Catherine approached me to talk was to go on the website for the Health Services and Policy Research Institute just to make sure that I was defining health services and policy research like the Institute defines it. And so what I'm talking about today really is this research and evaluation related to the Canadian healthcare system, policies related to that, and the use and all aspects of research and evaluation to do with the Canadian healthcare system. So I do want to start with a brief discussion of the word equity, or the concept of equity. It is a broad term, but in short, it's the goal that every person is equally able to live a healthy life. This includes equitable or fair access to healthcare professionals, to healthy food, to a safe living environment, and the ability to be well across all aspects of your life. Over time, I've really simplified my approach to defining and thinking about health equity. I've been working with this concept since I was a PhD student, and over the last about 20 years, I've really simplified it to say, you know, equity is about fair opportunities to be healthy. And so when we're talking about the Canadian healthcare system and research and evaluation associated with that, we are thinking about fair access to the system, fair experiences in the system, and fair outcomes of our interactions with the system. So I'll start in that first part of the presentation with 7 assumptions that are really key to kind of be a foundation for the rest of the work that I'm talking about. So the first assumption is that every human has equal value and rights. Depending on where we're sitting contextually, this might be really a given, but I think it is essential for us all to state some of these assumptions, no matter how obvious they might seem. So my first assumption is really that every human has equal value and rights. And I think it's helpful for us to be aware as researchers and evaluators of some of the documents that guide the formality of our thinking around human rights, including the Universal Declaration of Human Rights, the Ontario Rights Commission, and our Human Rights Code for Ontario, and the Canadian Charter of Rights and Freedoms. So the 25th article of the Universal Declaration of Human Rights specifically talks about the right to medical care and necessary social services, as well as a standard of living adequate for health and well-being. That's kind of that social determinant of health piece. So this is where we draw our connection in health services and policy research to human rights. But it is that first assumption that all people have equal value and rights. We have some specific documents that help guide us in, although everyone has equal rights and equal value, there are necessary documents to help guide our thinking around rights where there have been inequities. And so for children, for example, Indigenous people, people living with disabilities, refugees, et cetera, there are other rights documents that we can refer to. So the second assumption is that in an ideal society, every human would experience these equal values and equal rights. And this has the other piece that we are not in an equal society, or an ideal society, sorry, and we are not in this state, but yet that would be the ideal state. This is Joyce Echaquan. You know her because in September 2020, she died while in hospital in Quebec. She recorded herself in a live video, and she was being neglected and abused in a healthcare setting. This was just one extreme example, but we know that there's discrimination. We know there are experiences like this across our systems, and our healthcare system in Canada. And so this fact that we don't live in this ideal society is something for us to reflect on and think about for us as researchers and evaluators as well. So the third assumption is that every individual exists at an intersection between many aspects of our personal identity. So at the opening, I mentioned that my ancestors were from Scotland. I'm a white woman. I'm a settler. These are aspects of my personal identity. But in different contexts, I'm also a mother. I'm also an academic. I'm a tall person. I'm someone who lives in Ontario, etc. So I have all of these aspects of my personal identity, as do we all, right? So we have all of these intersections. And some of the intersections that we talk about as social epidemiologists kind of come to the top. So gender, sexual and gender identity, racial identity, socioeconomic status or class or income. These are some things that we have seen vast disparities in health outcomes associated, but there are many aspects of our personal identity. And so this is just one assumption. And then when we go to the next assumption, discrimination exists in groups in society based on these characteristics, and these lead to unequal opportunities to be healthy, so inequities. So this is Cara Jones. She's a social epidemiologist. She has appointments in a few different places, but the Rollins School of Public Health in Atlanta. And she talks about mainly discrimination based on racial characteristics, but I think that generally these three forms of discrimination are important for anyone working in this area at all to understand. So institutional racism or institutional discrimination based on any of these personal characteristics means that even over multiple generations, particular subgroups are privileged and others lack privilege or are intentionally oppressed. And institutions might have a very obvious policy that means that certain people get put forward and other people do not. But most of the time it's hidden. Most of the time it's a normative feeling that CEOs of companies normally are older white men or have been in the past. And this norm, it's a social consciousness that exists, and this is institutional racism or institutional ageism or institutional sexism that has been propagated over generations in a social norm. We have institutional racism that's really overt, like the residential school system. That was a whole system instructed to be specifically for Indigenous integration, and that whole process was institutional racism. This type of racism can be quite hidden. It's definitely part of our healthcare systems. People have differential experiences in the healthcare system because of the way social norms and expectations exist. And so institutional racism is an important aspect for us to understand, and institutional discrimination based on other aspects of our personal identity as well. Interpersonal discrimination is when two people are interacting and there is discrimination between them. It could be racial, it could be to do with someone's appearance in other ways. It could be things that you know about a person. There's sexual or gender identity, there's sexual or gender orientation, there literally any aspect of our personal identity could be something that you are then either privileged or oppressed around. And interpersonal racism can be something that is perceived as relatively small, like a microaggression, although that term, many microaggressions end up being super macro in the way they influence or impact people's lives over time. But interpersonal racism can be quite violent, it can be really overt, or again, it could be quite hidden. And then the third way discrimination is defined by Cara Jones is through internalized discrimination or internalized racism. And this is when you sort of believe negative aspects of your own stereotyped image about yourself. So you might limit yourself, or you might literally not like yourself, or you might not put yourself forward for something because you think that it's not the norm, or it's not something that you're meant to do or expected to do, or that you could do, you're not going to be good at it or whatever. So these forms of discrimination are important for us to understand. This is Stephanie Nixon. She's a researcher in Toronto, and she's talked about the coin of power and privilege and this coin model. So the idea that there are multiple systems of inequality that create structures of inequality. And on the two sides of that are the people who advantage or are advantaged by these systems, and those who are disadvantaged or oppressed by these systems. So in our healthcare system, there are many examples of it being the coin, the way we're treated, the way services are accessible or not in certain geographies, many, many examples where the healthcare system exists as that coin. So the fifth assumption is that in groups, there are people with different levels of power and privilege. And this has to do with your personal identity and how you've been discriminated against, disadvantaged, or not. And this woman's name is Sylvia Duckworth. She is actually a teacher, but she talks about how, depending where you'd put your finger on any number of these aspects of our personal identity, the center is a more powerful position from some kind of social hierarchy, and outward are usually less powerful, so potentially marginalized or oppressed, or this feeling of not being the preferred. And so it could be your age. It could be how you choose and who you choose to love. It could be your race or how you appear, your appearance. It could be your sex or gender, whether you're living with a disability or not. And so all of these pieces, again, this is intersectionality. They function to allow us to have power or not. And they function over multiple generations. So the fact that my parents were white and educated and a heterosexual couple, et cetera, gets passed on. And I start as a baby in a different position than someone else. The sixth assumption is that levels of power and privilege can be passed on across generations, which I just mentioned. You start with a backpack, or you have a backpack even as a child, and that backpack can have a lot of weight in a negative way, or it can be like a pair of wings in a positive way. So we definitely are not starting all from the same position. And then the final assumption is that intentional action is needed to create the ideal society I talked about, and to really surmount some of these other issues related to power and privilege and inequities. Okay, so it leaves us with this question of, well, what intentional actions could health services and policy researchers do or take to center health equity in their work and address negative impacts of discrimination and multi-generational imbalances of power and privilege? And this really takes to the second part of the talk, which is about the what. I thought it was helpful to bring a really concrete methodology with a model that we could kind of pick apart a little bit together. So this is Chandra Ford and Collins Erhihenbua. Chandra is from UCLA and Collins is from Penn State. And in 2010, they wrote this paper entitled The Public Health Critical Race Methodology, Praxis for Anti-Racism Research. And I focus on this specific aspect of racial discrimination because this model is specifically related to racial discrimination. But as someone who is also supportive of working on other forms of health inequities and other forms of discrimination, I think that we can apply their model to not just racial discrimination, but other forms of discrimination as well. So both Chandra and Collins are health crits. They call them they call themselves health crits. Critical race theory is the grounding of their work, and this attempts to move beyond merely just documenting health inequities or unfair opportunities to be healthy or unfair outcomes towards understanding and challenging power hierarchies that underpin these unfair situations. And so crits, that's the short form, these are critical race theorists. They're activists, they're scholars, they're interested in studying and transforming the relationships among race, racism, and power. And so health crits are those who are interested in the health aspects of that, health inequities associated with racism and experiences of it. This is the main model in their article. And you can see on the outside, it has an emphasis on race consciousness. So critical race theory has 4 distinguishing characteristics. First, issues of racialization. And so that means racial phenomenon, race, ethnicity, and racism are at its core. So that's sort of the main area of interest. So racialization describes how socially constructed racial and ethnic categories are used to order groups in society. All critical race endeavors focus on health inequities they begin by questions saying, how does racialization contribute to the problem at hand? How does it contribute to the health inequities? Accordingly, this bigger circle on the outside of this document is a race consciousness, and it brings us to say that we need race consciousness. It's fundamental to critical race theory, and it connotes an explicit attention to racial dynamics in the social world and our own place as researchers in it. So that very first, you can see there's sort of 4 focus areas. I know they're a little bit small to see, so I'm just going to make them a bit bigger. So the first one we're going to talk about is contemporary patterns of racial relations. And I put race in brackets because, as I mentioned before, I think this model could be used for social relations between different groups of different levels of power and privilege on any one of Duckworth's model of different social identity characteristics. So the contemporary racial relations focus. Health critics describe salient characteristics of race relations relative to a particular time period. So questions might be, what populations are currently most marginalized? By what mechanisms does racism affect this health inequity? And so these are some of the questions that we might be asking. So a conventional approach to this area might have a tendency to either be colorblind, so not mention race, or feel that race is associated with, let's say, class or socioeconomic status, and so we measure that aspect and not the racial aspect. Or we think of race as a genetic characteristic only. And so a public health critical race methodology, this model that Collins and Chandra are putting forward, might include these kinds of studies, like a study on neighborhood characteristics that include factors hypothesized to reflect institutional racism. So really focusing on how does institutional racism play out in a neighborhood. Another study might be a multi-level study considering the policy factors that are promoting residential segregation, that certain parts of the city, people are living in certain parts of the city, and how does that work? So this is public health oriented. If we try to flip this and say, well, what does a health services and policy researcher do? Well, these neighborhoods, these places where groups are being segregated also have health services. So really thinking about that and understanding that where these services are located have a whole social hierarchy and a geographic and social mix of influences there. So the second focus area here is the knowledge production area. So knowledge production, the purpose of this focus area is understand how racialization may shape the knowledge production process, or conversely, how the project may reinforce existing beliefs about racial groups or phenomenon. Health critics consider knowledge production to be socially constructed and subjective. And it's an enterprise where a specific discipline's norms or conventions inherently and largely negatively help to reinforce existing racial or other social hierarchies. And so in our production of knowledge, critical scholars know that knowledge is political. Knowledge, it is connected so deeply with power and privilege that we have to recognize that and try to unpack it in our work. So a conventional approach might be to totally ignore social categories or create what would be just an additive model. So you'd say, well, okay, we'll measure what race are you from, or what race do you identify with? And then we would measure, are you man, women, or other? And those things you would just separate out. A public health critical race methodology might instead say, well, if we're looking to reduce HIV risk behaviors among diverse men who have sex with men, you would stop to consider potential stereotypes, racial stereotypes, as well as other stereotypes that are underpinning our knowledge production and even the questions we're asking. You might determine that you need to do a study to assess race, not as a risk factor for a particular outcome, but because you want to identify a population that's at risk for specific racism exposure, and not the fact that they identify as Black or persons of color or white. So the third area in this model is conceptualization and measurement. The purpose of this focus area is to define a study's race or racism related constructs, the hypothesized relationships between these constructs, and the social context in which they exist. So it's critical that studies are appropriately conceptualized and that they're using the correct constructs that they're measuring. So a conventional approach might be the belief that empirical research is carried out properly and doesn't have to consider that social influences affect that study. This approach would routinely privilege majority perspectives, and it wouldn't allow for what public health critical race methodological approach would allow us to do in sort of conceptualizing the project differently. So you would take a disparities related literature review, for example, and you, instead of just determining what was in the literature, you would do that, but you would also compare where are the journal articles being published, who are the first authors. Those are different measures than just saying, well, what's in the literature, let's do a meta-analysis. The second point here, a researcher considers alternate explanations for findings than those that have previously been posited. And that is the fact that particular disciplines, you publish a paper, you can reanalyze that data with a social lens or with a health and equity lens and really come out the other end with a different, not necessarily debunking previous work, but literally coming out with just different types of findings because you're looking at it in a different way. And then the final focus area is at the bottom here around action. So white people and those with other privileges have inherited a legacy of silence and being able to walk away. Those with privilege have to own that and unpack it and continue not to walk away in situations of health inequities. So as a praxis, as a reflective methodology, the critical race process comes full circle when researchers use the knowledge obtained through their studies to help disrupt or to reduce or to abolish the causes of inequities. So a conventional approach might be quite a limited critical examination of how a discipline's norms might influence the knowledge production, but the public health critical methodological approach would recognize that all individuals possess experiential knowledge. These would be informed by the social locations and contributions of individuals from marginalized, and that their views would be prioritized, and that you would actively be engaging with these populations. Another approach would be to emphasize that institutional racism or other forms of discrimination reinforce majority group perspectives and remarginalization of minority perspectives, and to call that out in different public fora. You might draw on strategies of resistance, originating within the margins where resilience and creativity have been needed. And in these cases, researchers can maybe, I often hear, well, I'm a researcher, I'm not an activist, or I'm a researcher and I don't have the skills, I don't have the connections to do the advocacy. This is where collaborations, this is where using evidence to inform action and being part of that process, maybe not leading that process if that's not kind of your orientation, might be needed. And I would argue is needed. So I've said that I will take it back to the health services and policy research realm, like really directly, so that I do understand. I come from epidemiology. I know that some of this is quite social and it's quite theoretical, and maybe these broader topics can sometimes make our head hurt, but I'll bring it back to be quite useful, I hope, for health services and policy research land. So that's the how right now. So we have maybe 10 minutes to look at this. So if we think of the research process in three parts, we have our design phase, we have the data collection and analysis phase, and then we have our reporting or knowledge mobilization phase. So here are some questions. If you were a health services and policy researcher or aspiring to be that, here are some questions you might ask as you're coming from like a health crit lens. So what research questions should be asked to study and better address inequities? That's always the essential first question. We only have so many hours in a day. We only have one career, one life. And what research questions need to be asked? That is pivotal to all of our work. We spend days and weeks and years of our life focusing on whatever topics we're focusing on. And we have to know that these are worthwhile. I'm sure we have all kinds of ways that we make these worthwhile. But what I would say from a health crit or from a critical perspective, I would say at least give some of your time to working on writing the system of imbalance that we have in terms of power and privilege. Another question you might ask is, how confident are you with the data sources? Are they appropriate? Are they sufficiently capturing the needed variables? So if you're using administrative data sets, this is often an issue, a problem, that the questions just aren't worded right, or it only works on particular variables, or you only have information about particular variables and not others. And so part of maybe what our work is as health services and policy researchers is to figure out, how do we advocate for better data, different data, informing ourselves and educating ourselves about what it looks like to be using data that it might be effectively answering some of these questions. I'll give you some specific examples in a second. Another question you might ask in the design phase is, what are the needed variables? So what potential mechanisms underpin the inequities? So don't go too high up on the chain, but start to at least save some of your research time for further down and understanding some of these root causes of inequities. For example, could you include some measure of experience of discrimination rather than just identifying people as being part of specific social groups? Could you understand inaccess to healthcare? Could you understand even people's stress? One of the ways that discrimination gets under our skin and makes us unhealthy is through all of the stress responses that we have from baby all the way up to older age. Maybe that's something to really consider, understanding more about how these get under our skin. And then finally, what can you involve those with lived experience of specific inequities as team members, as advisors, as researchers in your projects? They have a specific perspective, and that gives them a privilege that you may not have. You may have, but considering this is important for all of us too. So this is David Williams. He's a real leader in the world of measuring discrimination. He has a fantastic TED Talk. He's at Harvard now, but he's been in all the big schools in Yale and in the States. And he has a validated scale for discrimination experiences that is worth looking at. This is the short form of it. So in your day-to-day life, how often do any of the following things happen to you? And it doesn't specifically mention race or any other social group. So this could actually be used across many forms of discrimination. And this gets at people's experiences and potentially what then is how it gets under their skin. So do these experiences change their behaviors, change their internalized racism or discrimination? Does it change their stress response? And then how over time does that impact their health? So the next stage in our research process, right, you have the design stage, and then you have the whole stage of data collection and analysis. So you might ask yourself as a health services and policy researcher, what analysis approaches are best used to identify inequities? So would you do a stratified analysis? Would you only look at the data for a particular group? Would you compare that? Would you adjust just for these social characteristics as confounding variables and continue with the exposure outcome main study? Would you do only descriptives and never kind of go beyond that? Do you want to do qualitative studies? When you do collect the data, who owns it? Who can use it? What can the data be used for? And were culturally appropriate approaches and tools used to collect the data? What about when approaches are approved or validated? What does that actually mean? Has it been validated in the right way with people who have experienced inequities, for example? What does an institutional rubber stamp mean on an approved approach? Even an ethics review board, sometimes, although they're getting very much better because of our advocacy, sometimes what they would approve as ethical may not be considered ethical by every member of the populations that we're working with. So this is, I mentioned Cara Jones earlier, she's a social epidemiologist. This is a somewhat helpful diagram, I think, that she proposed in 2001. If we were thinking about what kind of analysis to put together for a health services and policy research type of study. So the first question we would ask is, are there subpopulation differences in the health outcome that we're interested in? And if so, do we want to investigate them or not? So if we don't want to investigate them, if we recognize they're there, but we're not going to investigate them, at least we could document them. And if we don't have the right variables, at least we could try to advocate for getting them. Could we treat whatever that social identity factor or potential characteristic for discrimination as a confounder and adjust for it and see if there is some contribution of that factor to the outcome and what that might be? And then could you restrict the analysis to just a single group and sort of remove the potential for comparing apples and oranges here? If you do want to, though, investigate these health differences, there's a couple other ways that you can approach the analysis. You could stratify the data by that particular characteristic and explore the contributing factors by the multiple either levels or types, or the non and the yes in terms of whether they have that particular characteristic because of their experience of discrimination around that characteristic, for example. You could also adjust to quantify the magnitude of the effect. And you could conduct experiments to test reactions by that. So you could literally create sort of social experiments potentially, or you could use natural experiments that are existing and study those. So there are options. There are lots of different ways that you can think about doing this, but I think what public health critical methodology sort of guides us to do is to have that initial thinking and the initiative to want to do that. So one of the Canadian Institute for Health Information in 2020 put out some standardized approaches for measuring different, for example, racial groups. This is a contentious area, and it is helpful for institutions to try to come forward with some standardized approaches. Unfortunately, they're still not really there yet in terms of being perfect. So you have to weigh the pros and cons every time you're making a study. So for example, here we have white and Black as racial groups. They give the example of European descent. I've heard lots of Black scholars sort of say, well, I live in Europe and my ancestors lived in Europe too. So why can I not be of European descent? It's tough to, like when they say African Canadian descent, not everyone would identify with that. For example, they might just say that they're Canadian, they've been here for 200 years or whichever. So there is lots of contention still around the measures. And I think as you wade into this, if it's new to you, just be aware that we're trying and we have to be humble and we have to be open to learning. Making mistakes and trying to do this better is better than not doing it at all. And the second CIHI document in 2020 was about the Indigenous questions. This does appear to have a bit more uniformity and the sense that we can ask, do you identify as First Nations, Métis, or Inuit? Unfortunately, if we identify by this, the note below, it says it's recommended that reporting Indigenous identity data and communities be informed through engagement, etc. So by just describing inequities for Indigenous people, this can further stigmatize communities. It can be a negative approach to reporting, and it's not tied to action. It's not tied to appropriate decolonization, which is a real intentional act. So just asking and just reporting on really any of these characteristics, whether it has to do with disability or race or identity or literally any of these other social characteristics, we can't do that and just put it out there and say there are these differences without something that says, well, now what's the action associated with that, or the so what, how does this come about and how did it come about? And then the last part of our research process is this knowledge translation mobilization, this idea that we're summarizing, we come up to the results of our studies. We might ask things like, was sufficient care taken in interpreting and not overextending the findings? Can we say anything but root causes of some of the differences that we might see between the social groups within our studies? Is it appropriate to interpret it in that way? Is it appropriate to report it in that way? Yeah, will reporting the findings further stigmatize population subgroups? How can this be mitigated? If you have appropriate relationships and they guide the communication strategies or working with communities to use the data rather than just publish it, this may be possible to do, but it has to be really intentional. How will the results of the research lead to action is a question that we should always be asking, and whether we're active in doing that action or partnering closely with other people who can do it, at least making our research actionable is a key point. Continuing to partner with communities to raise more questions and generate hypotheses and share findings, making it part of your work to know people who are from communities that have historically experienced disadvantaged or discrimination or marginalization. This can help in figuring out what other research questions you can put into your research programs that will create the actions we need. And then finally, to continue to collect data by different socioeconomic groups or sociodemographic groups, if it's deemed appropriate, for those who are providing the data and everyone involved in your team, but be clear why you're collecting it and how to interpret those data. So that's near the end of my talk. I hope we have a chance to have a bit of a question answer discussion or comments of any kind. You know, I'm really thinking about this time that I spend as the Associate Dean of Equity and Social Accountability at Queen's as a time for learning, a time for us to be unlearning, to be relearning. It is a time of transformation at the university. I feel like we have great leadership. I feel like we have a real momentum. There's a lot happening at the university towards equity, diversity, inclusion, indigeneity, and accessibility. And I think that we can all jump on board. I would say that we're building a community of anti-oppression, and these are your pictures. I put in lots of pictures today of the different scholars to hope that, you know, next time it would be you that would be in here. I think that we all have a role to play, and health services and policy research certainly has a key role to play as well. So I would be happy for anyone to reach out and continue this conversation with me either today or later. This is my Twitter handle and my email address, but you can probably find me many different ways. So I welcome that. Thank you very much to everyone. I'm going to stop sharing, and I'll be happy to have a conversation or comments.
Thanks so much, Colleen. If I was looking like distracted, it's because I was writing down many things that you were saying in the frameworks, and so much valuable, yeah, so much valuable, really practical ways of thinking, but also actually of doing. And I just wrote a few quotes down that I'd love to sort of recognize and just talk about. Like, we only have one career, and, you know, we all hold these positions of power, and you know, how can we connect with our communities in a greater extent to make sure we're asking the right questions and communicating the right messages back in ways that are respectful. So I know lots of people have questions, so I'll stop talking, and people have been asking for the slides after, so we'll make sure we get these posted.
And you have been busy posting stuff in the chat as well. Good for you.
Well, I also know that what you were saying was enormously useful for people, and so people will see a number of different links. And there's a SSHRC document that you didn't refer to, Colleen, but it's actually quite excellent. And SSHRC's changed some of their policies about applications and really expect not an addendum about EDI, but actually like writing it through your proposal. And it was enormously helpful. Anyway.
Yeah, excellent. I'm hoping that the office, this Equity and Social Accountability, or EDI office, will, we haven't landed on a formal name, will hopefully be a source of support and active support for researchers when they're putting their applications in, because I know we're getting further and further pressure, not just from the social and community side, but from the institution side, like the funders and our partners, institutional partners who are saying, you know, what are you doing for sex and gender? What are you doing for EDI generally? How have you chosen to, you know, address inequities? And yeah, for people just starting out in this, it's great to have all the resources just at your fingertips, and then also for someone to look it over and say, oh, here's the paragraph we used, or here's you know, a helpful starting point. At least I don't think it's a checkbox kind of thing, but definitely it helps to have some of these resources to start with. Yeah.
Mm-hmm. And, you know, we see HSPRI as a research institute and helping people coalesce that as well. So if we can help health researchers, you know, put strong applications forward and conduct good research. So yeah, wonderful to work closely with yourselves. I see Joan and Elliot have their cameras on. I don't know if you wanted to have a comment specifically, or if other people have some questions.
Sure, I'll jump in here, Catherine. Great talk, Colleen. I really enjoyed that. I mean, sometimes as a health policy researcher, you don't see how this affects you concretely. I noticed with the recent round of contracts we're undergoing that they now have a required component of an equity lens, and they talk specifically about, you know, underserved populations, not necessarily identifying those populations, but you as the researcher, you're to do your due diligence in ensuring that. One of the things I just wanted to get you to weigh in on was, we were doing some knowledge translation on some of our recent research, and one of the big pieces that came back to us from the patient population was, we really can't understand this, and is it really realistic to expect your average patient to understand the research that you're producing? And so what they wanted us to do was to produce infographics or summaries of that research that was, you know, they could actually understand. How common is this, and do other people run into this?
Yes, they do. I don't know if it's overly common, but knowledge translation, I didn't gravitate towards there. I'm actually quite an introvert, analytic kind of person. And yet when you start doing health equity kind of research, you realize the knowledge translation piece, the communications piece is so critical, and the interaction piece. So like the fact that you're socially interacting with these groups and getting advice and understanding through experience what their experiences are. I've been working with some folks at Family Medicine. So a good colleague of mine, Eva Perky, I don't know if she's here today. She and I have done research along the border in Thailand, Myanmar, with migrants who are coming from Burma, from the Myanmar side, facing lots of adversities, they're ethnic minorities, etc. And part of the research was basically sitting with them and saying, okay, this is how to use an Excel spreadsheet to create a 2x2 chart. This is how to create a pie graph. And then this is how to use Canva, which is a free software, to make a little infographic with like a pie chart and a little 2x2 table, and put a title on it in your own language, and everything's in your own language, but then print that and take it to the clinic and say, you know, here are your, because they do collect data, they tend to kind of understand aspects of research, but the peer-reviewed papers, literally, we showed them papers that some of the people in these workshops, names were on, they were authors in them, and, you know, they didn't really understand, they weren't part of the actual writing of the academic piece. But sitting with them and saying, let's create a one-pager, let's do a little infographic, let's do a small written piece with a paragraph and some charts, that was helpful. So I do think that this is something that we should be doing, and it's actually not that difficult. A one or two page one or 2 day workshop where we I had to literally learn how to use pivot tables in Excel, because it's not something that I generally do, but you know, you take the YouTube videos like everybody else does, you learn it, and then you work with them to create it for themselves. So it's possible. You just have to have the intention to do it.
That's great, Colleen. So true. It's the intention piece and reaching out and taking that time.
Yeah.
I think you were going to say something as well.
Colleen, that was outstanding. Just outstanding. Thank you so much for sharing that. And I love your description of an introverted analyst. I like that. So that's me. Yay. What I struggle with, there's two things, because most of my work predominantly is with secondary data. So we don't have really the opportunity to explore a lot of the continuum of equity variables. But I know it's getting better. So some discussion about how we can integrate or marry the different analytical approaches so that if I do a sex-based analysis, that we need to build upon that. Well, what is it within that sex-based analysis that we need to explore further, whether it's, their geographical location or their whatever. And I don't think we integrate our approaches well together. Doing that population-based approach, you get some really important data, but it's not enough. So we need to be able to drill down more with what our different approaches. And the second thing I struggle with is that, and maybe it's just my value, I don't think it's black and that's probably not the right term, that it's a continuum of equity imbalances. So the power struggle, like I may not feel that I'm being oppressed, but there are certainly oppressive things that go on within my career and within my work. But I wouldn't say I'm an oppressed person, but I probably have experienced that needs to be corrected. So I think there's a continuum of equity, and I don't think we address that well.
Yeah, no, so your last point, I agree. And I've tried to, because I think Catherine pointing out, like, that you only have one career, you only have so many hours in the day. So I've tend to gravitated towards the more extreme cases where literally the inequities are undignified and really need retribution. That's just me, though. Other people, I mean, you can look at equity anywhere along the continuum as a researcher or in your own personal life as well. And when you look at that model by Duckworth, and she has all of those pieces, you can kind of look at all those characteristics and say, yeah, I've experienced a bit of marginalization because of that, but in the overall, I've been pretty close to the center of that model. So it's maybe not something that I want to focus on, but then other people, it's really been impactful on their life that they were influenced by a particular microaggression or limitation, or, and those things are important to kind of differentiate. I also feel like we need to give ourselves permission to air these discussions and really talk about these multiple privileges and kind of layers of privilege and multi-generational privilege and the guilt and all aspects. It's complex conversations. So we just bite off little pieces. The first question you said around kind of using other methods and that we might marry different, I totally agree. And that's another reason why I sort of gravitate a bit towards mixed methods, because sometimes when you're working in the area of health inequities, you realize, like, I just can't do those big data set anymore because there's just no depth to understanding the experience of why or what the action should be. We can keep pointing out that there's differences, but it gets a bit old when you keep saying the same thing. So if you're not prone to want to learn qualitative or community-based research, then maybe working in conjunction with others who want to do that, or getting to know a social scientist and working in collaboration to have a two-part study where they do one part and you do the other. I mean, it's absolutely fine to continue working in epidemiology as kind of a larger data set approach. And then I would just say, even in that approach, we've started talking, for example, at Kingston Health Sciences Center, how can we collect data about the social determinants of health? What is their housing like? How is their income? How stable has their income been? Adverse childhood experiences. These kinds of things are sometimes difficult to integrate into our data sets, but not impossible. And there may be ways to understand experiences of discrimination and have that as part of our OHIP data somehow. So again, it's like a longer conversation about what we have counted as important up to this point may not be everything as we go forward. Yeah. I see mention from Sierra about, is that Global and Population Health 493 Jen Carpenter's course in Bachelor of Health Sciences? I'm guessing there.
And I'm going to echo that this should be a foundational talk in really every research methods course. I teach it in the School of Rehab, and I will connect with you, Colleen, for the beginning of next year. You point out the data gaps, like, what aren't we measuring? And, I'm just going to even bring up, like, we are just measuring in large data the health system. And, a lot of people access their supports for health and well-being outside, like in these community supports, families, religious groups, and again, we're only looking at the health system, and that whole avenue of finding out how people get supports, particularly on the margins, I think is so crucial. I'm not sure that you have an answer to that, but just to kind of reflect at that point too.
Yeah. It sort of depends what our questions are, what our research questions are. I don't want to devalue like very clinical kind of questions and the kind of work that a lot of our colleagues and you guys are doing. So, not every question needs to be a social and community question, but just to kind of put it out there that even when we're studying outcomes of like literally any study related to health systems and services, there is a social component, right? And there's a power and privilege imbalance. And so just considering it from the start and then figuring out, is this something that I want to integrate, and how much do I want to integrate it, and how much can I really connect to an action around this? Those are all questions that maybe as researchers we can reflect on ourselves.
Mm-hmm.
Paul, I have to congratulate Paul. He's one of our mental health heroes today, student hero, because he's so integrated in mental health research. So he's one of our public health PhD students. Nice to see you. Do you have a question?
Oh, thank you so much, Colleen. Yeah, so my PhD, thesis also deals with, a little bit components of equity and stuff like that. And it makes me think a lot, coming from Thailand, a place where very homogenous, you're mentioning there's lots of people around the, in the borders where they face inequalities and all that. Listening to your talks and me thinking it too, I try to not, stereotype people or categorize people into, certain groups, but sometimes categorizations kind of make things being heard a little bit more, because people do have, an idea of, okay, this is what an immigrant looks like. This is what, a person of color looks like. I just want to know, like, where's the balance in terms of thinking when it's very delicate. I would think, where's the balance in terms of when is it time to, specifically mention a group, or when is it more focused on the experience? The other thing, the other questions, I guess, but I guess very short one is that, like, sometimes problems these days are brought into research through large data and through observations. Let's say that you look at a data and we see, oh, there's like some sort of, inequalities that we see from a data set, but not driven by the actual experience of people who actually experience them and not being brought to us. So how should, going back to the design phase, so what should guide us in terms of like what questions should we ask? If it's never been, I don't want to say the word complain, but it's never been evident in the real world, should we bother going into exploring those inequalities that we see in an Excel spreadsheet, for example?
Yeah. Well, we have a minute to answer those big questions. So I'll just say, you're allowed to do research in your own interest area, but I guess I would encourage us all to get interested in the fact that there are undignified differential health outcomes. And that's the first place maybe to start thinking about, like, which ones are just really so bad that we need to address them and not allow them to continue another day. But for the other ones, continuing and being part of the conversation for anti-oppression, I think we can do that in lots of different ways. I appreciate your question, Paul, and I don't have enough time to answer it in fully, but we're all part of this. So we'll continue these in lots of different forms, I hope, over my time anyway, as Associate Dean and further. I've really enjoyed being here today.
Colleen, I just want to wrap up and say thank you. There's so much interest in this area, and just a great way to start 2022 in a thoughtful manner, and really appreciate you giving us your time in the first month of your position. So thank you very much. And I hope everyone has a great rest of the day.
Yes. Thanks, everyone. Bye.
Bye.